What's that? 2. All right, so yeah, aromatase is an enzyme, converts androgens to estrogens. So we want to give anybody that's, ER positive, they're responsive to an aromatase inhibitor. Anybody used to like bodybuild in here? Anybody ever taken an aromatase inhibitor? It's like a common thing you see when they cycle in bodybuilding. All right, good. Here's another question. Which, when we're talking about these receptors here that we can check, or expression of, which one has the highest risk of like recurrence and metastases? Okay, triple negative. Here's another one. I think I'll give y'all some review because you probably didn't teach it appropriately, and I need to make sure you guys understand it all. This one's tricky, right? I know you're sitting there like, 2 right answers, isn't there? All right, so they come with, breast pain or mastalgia. We don't find any masses on exam. It's bilateral. What are we doing first? I like that. Nothing. Yep. So lifestyle. Okay. What if lifestyle wasn't on there? It wasn't one of your options. What else? What would you choose then? Yeah, ensign. Good. All right. All right, today we're talking about the abdominal wall, mostly hernias. We'll talk about some groin pain as well. Here's what we're going to go over today. We'll look at the anatomy, which is important, just kind of identifying what type of hernias we have, just based on anatomical structures. All right, so hernia is protrusion of tissue through some sort of fascial, muscle layer, or other barrier that's supposed to contain them. And then most of them are inguinal hernias, whether that's direct versus indirect, and we'll talk about that. And then a femoral hernia originates below the inguinal ligament, and an inguinal hernia is above the inguinal ligament. So it's important we differentiate those. And on exam, it can sometimes be difficult identifying these, but hopefully, with practice, you guys will, be able to identify it. Typically 2 of them have some sort of palpable bulge that you don't have to, do your normal, invagination of the inguinal canal. And it's sometimes easier to identify those just based on exam, because you can visualize them. But I think we kind of mentioned it before, the difference between incarcerated and strangulated. So incarcerated means I can't reduce it, so I can't push it back in. And then strangulated means that they have some sort of ischemic and incarcerated hernia. So that's an emergency. And then most of these are congenital defects. Some can be acquired from trauma and prior surgeries. All right, here's all the different kinds of hernias and where they can sit in the body. So the epigastric, that's between the rectus and abdominis. Anything from umbilicus to the xiphoid is what we consider an epigastric hernia. We have our umbilical hernia, which is pretty self-explanatory. It has some sort of defect through the umbilicus. Then we have our Spigelian hernias, which are less common, and we won't talk about them very much here. Surgeons love the Spigelian hernia, though. It's like some magical procedure they love to do because it's different than all the other hernias. All right, and then we have our direct, indirect, and then femoral, or we're going to spend a lot of our time talking about today. And then here's just tissue layers and where those hernias can kind of run through. And the one we'll talk about the most is that inguinal ring and that indirect hernia. As you can see, all the structures that run through there. And then groin hernia. So here are different kinds. So indirect, direct, and femoral. Indirect is going to be our most common, and that one develops at the internal inguinal ring, and it's lateral to the inferior epigastric artery, which doesn't really matter because it's not something we can evaluate on exam. Like we're not sitting there like, oh, it's right there by the epigastric artery. On exam, what you'll do to palpate, obviously you should be able to feel a femoral pulse in that area, and then we should be able to figure out where that inguinal ligament is because it comes from the ASIS and attaches to the pubis. So those are palpable landmarks that we can use, and then we also are going to talk about the Kieselbach's triangle, and we have some pictures here, but that's the inguinal ligament inferiorly, the inferior epigastric vessels laterally, and the rectus muscle medially. And then femoral hernias develop in the empty space. So this is, and we'll talk about it, this is probably the worst off hernia because it usually presents with incarceration. It's like uncommon, more common in females. And we'll get into the details on those, but it has the highest risk of incarceration and strangulation, and they typically don't present until that happens. But risk factors, anything that increases intra-abdominal pressure is going to be a risk factor for hernias. And the most common being the indirect, and it's congenital, so there's some sort of defect from birth. And a lot of times we don't notice it till we're a little bit older. There's our a great pictorial representation of Kieselbach's triangle. So there we have that lateral border of the rectus muscle, inferior epigastric artery, and the inguinal ligament. All right, so indirect inguinal hernia. So there's some great pictures there. Obviously, that one's probably incarcerated. So it's a congenital hernia. Some of them are found like in the first couple of years of life, but most of them aren't noticed till later in life. So typically it's congenital hernia through that patent process vaginalis. And then it's the same defect that you're going to see with hydroceles, which we're going to talk about later, and you'll see these in practice commonly as well. But basically the intestinal contents track down that spermatic cord, and it goes through the inguinal ring, and that's when you're going to be able to palpate it on exam, or if it's incarcerated, you're going to hopefully be able to see it on exam. But they'll usually complain of a bulge in the groin, usually worse with activities, lifting, anything like that, or weightlifting, working out, they'll have some sort of pain. And then they may notice a bulge in that area on self-exam. And then if it's, significant, like incarcerated and strangulated, they'll have typically like nausea, vomiting, severe pain, they'll present septic. All right, so there's another representation there that you can see the deep inguinal ring and those abdominal contents that protrude through it, which is why we do, our hernia exam the way we do. Did I tell you guys a story about my hernia exam with the colonel? Yeah, I did. When he had my hand and was teaching me how to do it. It was interesting. We're not going to do that today, don't worry. All right, and then we have our direct inguinal hernias. So these are required due to some sort of weakness. Weakened floor of the inguinal canal, and they normally enlarge with time. These ones, typically, you can see them on exam if they are incarcerated. What makes these exams difficult is, if they're weightlifting or depending on how large the defect is, it's hard to evaluate it because you won't feel anything on exam. The patient's like, did you feel that? And you're like, no, I don't feel anything. So we'll talk about what we do for the workup with these, and it's actually very easy. All right, risk factors, obesity, anything that like increases intra-abdominal pressure, so obesity, pregnancy, heavy lifting, the chronic cough. We see this a lot with our like prostatitis patients, or that have some sort of chronic prostatitis. Constipation is a common one as well, and some of these things we can manage in our patients pre-op or before the surgery, because most of these are elective unless it's incarcerated or strangulated. But like I said, they're going to have some sort of bulge in the groin. It can be acute versus chronic, and then they might have some sort of abdominal distension. And that's especially dependent on obviously patient factors and what sort of comorbid conditions they have. But It normally doesn't extend to the scrotum. When it does, it's usually incarcerated at that point, and we're not able to reduce it. So what do you guys think our job is? To reduce it. And then if we can't, then they immediately go to surgery. That's a bad sign. But these ones, yeah, you know, they say you get it from some sort of chronic overstretching of that area. And then, I don't know what the actual percentage is. It's like very low for the direct inguinal hernias though. All right, so diagnosis, there's a great picture of the exam there and how we're gonna perform that. So obviously, you're gonna have them supine, standing, coughing, straining, and then you're just gonna imaginate the scrotum. You're gonna take your index finger and palpate to the pubic tubercle or lateral of the pubic tubercle, and then have them cough or strain on exam. You also, it's important to do a testicular evaluation, and then depending on the patient and comorbidities, you may or may not do a rectal exam. I don't do a rectal exam on every one of these. In female patients, this is a lot, you know, this isn't something that's easily, that you can easily evaluate on exam. So we typically get an ultrasound for them. I mean, we get an ultrasound for all, you know, men and women, but typically with females, it's harder to evaluate just with outpatient. So we'll typically get the ultrasound for further evaluation. And then how do we diagnose it? Obviously, our physical exam is important. History is also important. What sort of activities cause them to have symptoms? If it's incarcerated, it's, you know, it's usually pretty easy on exam. Okay, there's some sort of palpable bulge there, but when it's not, then we need to get our groin ultrasound. If we determine it's incarcerated and we can't reduce it, that's like we need to call the surgeon and get them to surgery. If that isn't the case, then we need to start with our groin ultrasound. It's usually our initial diagnostic test. It's probably the best test for this. CT can also evaluate this, but it's a little bit more difficult because unless it's incarcerated, the CT may or may not show anything because it might not see that as like fascial defect. And then if it's reducible, then it's a routine surgery. And you do have to have a discussion with your patients because they want it done right now. And if you reduce it, then they're a little disappointed if they can't get it fixed immediately. So it is just an elective inguinal hernia repair. And then we just refer them to the surgeon at that point. And like I said, if it's incarcerated, or strangulated, then we need emergent treatment for that. All right, so what do we do pre-op? So we want to manage our chronic comorbidities. So it's important we assess the patient. We need to ask them about the bowel habits as well, because constipation is a common one that could cause that increased abdominal pressure, like when they're on the toilet. So we can give them stool softeners. Anybody know a stool softener that we commonly use? Docusate, yeah. So Docusate is typically the one that you can give to help them soften that stool. And then obviously if they have some sort of prostatic hyperplasia, BPH, or they have risk for urinary retention, we need to consider that before the surgery. We certainly need to get a urinalysis on them. All right, so how do we treat it? I mean, they're all going to get surgical repair, and then it just depends on whether we do an open versus a closed or versus laparoscopic technique. Laparoscopic is typically better for like bilateral or failed open repairs. Open repair is more common for like initial unilateral hernias. I've only done laparoscopic, but these are assisted in laparoscopics. I've actually never seen an open repair, but apparently, it is the more common technique that they use, just because the laparoscopic has a higher recurrence rate as well. We're concerned about in mesh failure. One of the complications we see commonly with this is there's the ilioinguinal nerve. Sometimes that can get entrapped in the mesh that we place in there for the repair, so that is a very common complaint we'll see afterwards. And there are treatments we can do for that, like ablations and other things, but it is very common. They'll complain of like chronic scrotal pain or pain anywhere in that area. And here's some of our general indications. I mean, typically the only time we're doing laparoscopy is if it's bilateral, or they need earlier return to full activities. All right. So what are the complications? So obviously more complications with recurrent and large hernias. Sometimes with like a large hernia, they'll repair bilaterally when they do these procedures just to avoid any recurrence rate. And then like in any other surgery, we have bleeding, damage to other structures. Like I said, that ilioinguinal nerve. Sometimes they'll do like a prophylactic division of it to decrease chronic pain. Then we gotta worry about infection, like wound dehiscence. And recurrence, like I said, is more common with the laparoscopic technique versus the open. And there's your common recovery time there. I want to say usually like 4 weeks, they can start lifting lighter weights, and then typically by 6 weeks, most of them are recovered. All right, and the femoral hernia, so this one passes below the inguinal ligament. And this one is more common in women, and it's more prone to, like I said, incarceration and strangulation is usually their initial presentation. Like almost 0.5%, with an incarceration or strangulation on exam when you see them. And as you can see, like when the femoral hernia descends through that femoral canal, so you can actually usually palpate in the area, you can feel where that femoral artery is, and usually it's medial to that. And this one, typically presents with groin bulge, pain. They might have nausea, vomiting, signs of obstruction, especially if they're incarcerated. The bulge is going to be worse by any sort of straining, valsalva, cough. Usually non-tender, but this one typically all of them are going to get surgery. It just depends on if we can reduce it or not. If it's stable, we can reduce it. Then the elective, we'll send them for an elective surgery. If not, we have to urgently repair that. So here are incarcerated hernias. Like I said, so obviously you cannot reduce it, and it may or may not be well perfused or ischemic. If it isn't, then we call it strangulated. And this is why it's important to reduce them. So you may have to give them some sort of medication. I mean, typically, like Versed is a common one I give them prior to attempting this. I'll attempt it without first, but typically when we try to reduce these, we'll give them some sort of sedative or anxiolytic to help relax them a little bit. Sometimes, I hate to say it, sometimes I surprise people and, all right, try to reduce it right there, just to expedite it. It's not super painful when you do it, but if you can't reduce it without any sort of like sedation or anything, sometimes you'll have to give them some. So it doesn't need to be like a conscious sedation or anything, just something to help them relax. And then obviously, if it's incarcerated and we see signs like strangulation, they'll have leukocytosis, fever, they might have some ischemia. A lot of times, if we can't reduce these, we'll send them for a CT scan, which can evaluate whether they have actual abdominal contents permeating through that area. So at that point, you know that they have this hernia, so we'll send them for a CT scan. Any signs of peritonitis, that we need to immediately get them to surgery. And then here are some of the other ones we have. So epigastric hernia. So this is through the linea alba, but it's above the umbilicus. Most defects are relatively small, and they usually contain just peritoneal fat, or preperitoneal fat. if they had any sort of operation, and it's not, it's more common to see this. Some people do have it just spontaneously, but especially if they've had some sort of procedure there, you need to suspect this. These ones typically don't have a ton of complications with them. And it's going to be the same presentation, typically a bulge. And we have great pictures of these bulges, but most of the time it's not a visible bulge, but on palpation you can speak, you definitely feel a bulge there. And these are for all of them. I think I actually see, we'll talk about it next, but I think I see umbilical hernias. I don't know why I see more of those than other ones, but I feel like I see those more frequently. But obviously ultrasound is going to be our first test for these. And then a good history, physical, we need to know if they had any prior surgeries. And then most of these are going to be elective, outpatient referrals. So, if they can't tolerate the surgery, they have, comorbidities and anything like that, then they can, we have the abdominal corset they can wear.
So for that non-surgical candidate or surgical candidate, is that something you could, obviously not from the ER setting, but from just the primary care setting, you could refer them over to therapy for abdominal wall exercise?
Yeah, I'm sure you can.
I imagine facing clients with a corset is.
Yeah, I've never prescribed a corset. Typically, so a lot of times, especially the umbilical ones that I treat, a lot of times it'll be a soldier, very small, like pea size, it's easily reducible. We'll send it for an ultrasound for further evaluation, and then we have to decide, we have to look at the risk versus reward. So a lot of times, especially in a military setting or operational setting, we'll notice that, you have to decide whether you have enough time that we can fix this before deployment, so you need to consider those factors as well with these, okay, can I send them to surgery? Because I don't want to deal with this downrange or wherever we're deployed to. So that's some of the decision making you're going to have to make and talk with the patient about it, and put it in referral too. Because sometimes they may manage them non-op, but if they have a higher risk, hey, they're going to be wearing body armor, carrying a load, and we're going to be in the middle of nowhere for 6 to 9 months. We need to get this repaired, so it's that's an important consideration too. And there's the umbilical hernia. So yeah, we commonly see this in newborns. It typically spontaneously resolves. Parents are going to show up freaking out about it, which for good reason. So usually, like an adult, it occurs long after closure of the umbilical ring. Typical patient has usually some sort of increase in intra-abdominal pressure. You'll see it in the mold tips. Anybody with ascites, obesity, a lot of times in the ascites patients, they'll have just a chronic one that's always there and visible, and there's not a lot we can do for it at that point, especially with their significant bleeding risk and coagulopathy associated with that condition. But these do run the risk of concussion. What's up?
So with a newborn child, would you just tell that parent, when it pops out, pop it back in, and hopefully it'll stop doing that too? Or is it?
Yeah, that's a good question. I haven't seen one that significant, so typically they're pretty small. So, and yeah, I just typically counsel them that it's going to resolve and it's not a concern right now. I don't know tell you on that one that large whether you want to push it back in or not, or try to reduce it. Typically they're benign. All right, so here's our umbilical hernia there for the operative repair, typically open procedure. I feel like I can do this one actually. You just kind of make an incision on the umbilicus, and then you put some mesh over it and close the defect. But these are going to be open procedures. Sometimes if it's small, they can just do a direct suture repair on these. All right, and then we obviously have incisional hernia, so for any procedure, we do worry about the risk of an incisional hernia. Now we have a higher risk if we have any sort of operative site that has dehiscence after we close them or in the post-op period. But most of the time we'll see some sort of wound infection with it is a common risk factor. Any sort of increased pressure like cough, obesity, comorbidities, immunocompromised. And they'll complain of usually a bulge and then some sort of local discomfort in the area. If you know, if we see like salmon colored fluid or any signs of infection, then we need to, in the post-op period, then we need to open that back up and possibly take them back to the operating room for washout and repair. And then this one, yeah, they talk about, you know, depending on where the location is, they may get an abdominal binder. I can imagine people being very compliant with that, but that is an option as well if they're not a good surgical candidate. And then here's our wound dehiscence, like I was talking about, any sort of like salmon or abnormal colored discharge coming out of there, especially if there's peritoneal fluid. We need to take them back to the OR for a fascial closure. So this is more of an emergency, especially if we're seeing this in the hospital as we're rounding post-op. We need to evaluate their wound site, determine whether it's infected, and then take them back to the OR. I mean, so could you imagine, like, what would you think of that patient? Like, that patient came in, I don't even know what would go through my mind, like, what it could be. It's like a sideways pregnancy looking thing, like, what is this? So, I think it says it was like from a prior repair of the, what was it, the lateral, or the right lumbar incisional hernia, so. It says it's 6.2 liters of fluid is in there, or not fluid, abdominal contents is in there, so that's pretty significant. Yeah, I'm just wondering, I wish I knew the history on this, like, did this dude walk in, or girl, did they walk in? Like, I don't think, that's pretty significant. I mean, it looks like, obviously, it was quite a while post-op is what it looked. I don't see any, like, incision or anything, so it's interesting. All right, and here's a good picture. So this is like how our body is divided, like when we talk about the retroperitoneum. So it's a great little pictorial representation of what's in there. A lot of times we talk about the retroperitoneum and we just say, oh yeah, this is the retroperitoneum and what structures are in it. But this is why we say it, because our content, you know, we have those layers and different contents in those areas. And they can separate themselves off depending on what sort of pathology they have. All right, and then we have diastasis recti, so that's widening the linea alba, probably most commonly seen in pregnancy or post-pregnancy patients. And then you can see it with, you know, obese and then any sort of increased abdominal pressure, like with ascites, large tumors. And this one's not technically a hernia. But this is the one on exam when they raise their head, they'll have a prominent midline bulge. Repair should be avoided. They don't have a risk of incarceration. We do repair these frequently, especially if we have our younger patients. However, if they're going to become pregnant again, then we might not do it. So a lot of times you'll see this get repaired, you know, after they're done having children. They've had 3 or 4 children. And they're still trying to have an active lifestyle, so sometimes we'll repair them in those instances. All right, let's talk about some groin pain. So, very common presentation, you see this a lot, especially since we typically have a larger male population in the military. So we're gonna get a lot of groin pain and have to evaluate these. And we'll talk about the ones that need surgical management. All right, so sports hernia. So this is typically like a tear of the external oblique aponeurosis. It's not an actual hernia. These ones are tricky to diagnose or manage because we can't actually find a hernia, but they have some sort of pain. Most commonly, we'll find some sort of adductor cause and they don't require any sort of surgical repair for this. So these ones are typically going to get managed with physical therapy for further evaluation. You know, if we need to do any surgery, like if they have like any sort of pain that they can't do their activities of daily living, or they feel conservative treatment, we can do surgeries on these. But most commonly not. Typically physical therapy fixes these. And it's usually an adductor cause. So one of those adductor muscles actually has the same innervation to the testicles. So that's why they'll complain a lot of times with testicular pain. And sometimes with torsion workups, we'll find that it's some sort of adductor muscle spasm or tear that's causing this versus an actual testicular cause. All right, hydrocele. So this is going to be like a fluid-filled sac next to the testes. Most of them are asymptomatic. It's not typically going to cause any sort of pain. They can transilluminate on physical exam. They're not tender. And this is typically congenital. And we don't really do any sort of repair for these. Now, I don't know who would aspirate this. That's pretty funny. Guys don't aspirate this. Like, if you're aspirating anything in the scrotum, that's probably a bad day. But you can get an ultrasound for these, and then if it's large enough and it's causing irritation, then we can refer them to surgery. But these are typically like, if we have to, it's an elective repair. Most of them are pretty small. And epididymitis. So this, we're going to talk about groin pain for surgery, but this obviously isn't a surgical patient if they're presented with epididymitis. Typically this is not groin pain, it's testicular pain. Usually acute onset, especially, so we kind of stratify these whether they're younger versus older. Typically it's like a rough rule of thumb. We say 35, I don't know where we do the cutoff, but really whether we think they have a sexually transmitted infection or not is where we're kind of basing our treatment on. So since we don't get STI panels back anywhere in a reasonable amount of time, it just kind of guides what sort of antibiotic management we do for these patients. But on exam, you're going to palpate the testes, and you're going to, on the superior portion and a little bit posterior, you'll feel kind of a squishy, inflamed epididymis. The patient will usually have significant discomfort, more commonly unilateral, and then we need to get a good sexual history on them. And then typically they need to get some sort of STI treatment. We'll do the STI panel, and if they're in a monogamous relationship, they're older, we'll typically give them some sort of fluoroquinolone. If not, then typically we do the Rocephin and doxycycline like we would do for gonorrhea and chlamydia treatment. NSAIDs help. You can give them scrotal support. But this diagnosis is based on your history and physical exam. All right, so epididymal cysts, these are typically asymptomatic. You're going to find them on palpation. It's important to differentiate because they're asymptomatic. A lot of times patients will present and they'll say, I have some sort of testicular mass. And typically when you hear that, you need to think, oh crap, do they have testicular cancer? But this is something once on your physical exam, you're going to notice when you actually palpate, and you should be able to differentiate whether it's a testicular mass versus an epididymal cyst. Used to be more common in men that whose parents were treated with DES during pregnancy, which they stopped doing like in the 70s. It was something used to help prevent miscarriages. It didn't prevent miscarriages, but it took us like 30 years to realize that, oddly enough. So we don't see a lot of these anymore. But the ones that like I've seen are usually elderly that have a lot of these epididymal cysts, and some of them are pretty large. Like I've had like 6 or 7 centimeter ones. I had a guy with like 3 of them that were extremely large. I have no idea how he was even like walking around normally with them. I was like, how long has it been like this? And he was obese, so maybe that's why. But yeah, they were extremely large. So it's a benign finding. You get an ultrasound with them. If they have the chronic pain or any irritation with it because of the size, then we can look at doing a surgical excision. All right, here's our varicocele, so our dilated veins in the scrotum. This is that bag of worms as we always described it in the textbook. Typically left-sided. So because of the drainage of that area, we typically we'll see it on the left side, because we can have like a reflux there, and the left gonadal vein drains into the renal vein, and it's like an angle that doesn't drain well. So typically it's only seen on the left side. If we see this on the right, or later in life, we need to evaluate for some sort of mass occluding the vein. So these ones, if you see this, you need a unilateral right-sided, you need to get a CT scan of the abdomen and pelvis for further evaluation of these. But this is very common too. You're gonna see a lot of these, especially with like our predominantly male population. And then testicular cancer. So any mass on the testicle during your evaluation, you need to rule out testicular cancer. So this is an urgent referral for ultrasound, and then if obviously they determine it's cancer, then they need to go to surgery, but a scrotal ultrasound works very well for these patients. It's typically like a non-tender, it's not gonna be painful mass on the scrotum. It doesn't transilluminate, so these ones immediately you should be suspicious for cancer and send it for an ultrasound. Like this and the torsion are the two emergencies you need to think about, the testicles, and they need immediate ultrasound. And then if you determine it is cancer, then usually immediate urology versus surgery, depending on what you have at your hospital to take care of this. Sometimes it can have associated gynecomastia with it. And then here's our other emergency. So this one's typically extreme testicular pain. They'll, possibly have nausea, vomiting, sweating. Usually after some sort of strenuous activity, they notice that they'll have tenderness in the inguinal canal. This is an urgent Doppler ultrasound, so we need to evaluate flow to that testicle. And then if it's determined that it's torsion, then they need urgent surgery. So typically they say like 6 hours. The testicle can still be viable. We see it more commonly like if somebody has a bell flapper deformity. And then this one is typically handled by urology. They can do an orchiectomy if it's ischemic or necrotic and they can't save that testicle. All right, that was a short lecture today. What questions do you guys have? How do you guys feel about the other lectures? Have time to digest them? You got questions? Might you guys have something?